Hello, this is the Unit 4, Module 11, Chapter 22A presentation. The big picture coverage for this half of Chapter 22 includes the anatomy, physiology, and ecology of the skin and a description of bacterial skin diseases. The skin is a remarkable organ, the largest in the body. It provides strength and flexibility in a single smooth sheath. The skin is sensory. It retards the loss of water. It synthesizes various chemicals, including vitamin D. It contains immune system cells and prevents the entree of harmful substances and excretes small quantities of waste. It also prevents microbes from entering the body. The integumentary system, then, consists of skin, hair, nails, sweat glands, and oil glands. The skin contacts the environment directly. Many infectious diseases include skin eruptions or lesions as part of the course of illness. The barrier defenses of the skin include the epidermis, which is a keratinized surface. There's a constant sloughing off of cells from the stratum corneum. The barrier defenses include chemical defenses and oils, as well as sweat. The antimicrobial substances secreted by the skin on its surface include sebum, sweat, and antimicrobial peptides in the epithelial cells. Who are the normal members of the skin microbiota? Well, they include species of Pseudomonas, a number of gram-negatives, Staphylococcus species, and other firmicutes. And the other types of firmicutes, which are the gram-positives, are in proportion to the moisture content of the particular site in the skin. The requirements for a microbe to be able to live on your skin include the fact that it must be able to live in a dry, salty condition. Microbes grow in dense populations in moist areas of the skin and skin folds, or in hair follicles and glandular ducts. Propionibacterium acnes is part of the normal skin microbiota. Propionibacterium infects hair follicles. The body's inflammatory response to propionibacterium is what causes pimples. This condition is readily treated with topical antibiotics. Propionibacterium are pleomorphic, anaerobic, gram-positive rods found on both the skin as well as the gastrointestinal tract. Propionibacterium acnes can cause catheter and shunt infections, and it is often involved in mixed infections associated with cat and dog bites and in head and neck abscesses of the skin. Acne vulgaris is a disorder primarily of teenagers and young adults, although 10 to 20% of adults may continue to experience the disorder. The permissive factor in adolescence is the increase in sebum production by sebaceous glands after puberty. Small cysts, called comedones, form in hair follicles due to the blockage of the follicular orifice by retention of keratinous material and sebum. The activity of Propionibacterium acnes within the comedones releases free fatty acids from sebum, and this causes inflammation within the cyst and results in rupture of the cyst wall. Further inflammation develops as a result of the extrusion of oily and keratinous debris from the cyst. Furunculosis is caused by Staphylococcus aureus, and this disorder has gained prominence in the last decade because of community-acquired methicillin-resistant Staphylococcus aureus. A furuncle, or a boil, is a painful erythematous nodule that can occur on any cutaneous surface or in any infected hair follicle. The lesions may be solitary, but are often multiple. Furuncles can rupture and drain spontaneously, or may need incision and drainage, which might be adequate therapy for small solitary furuncles without cellulitis or systemic symptoms. An aggregation of furuncles can create what's called a carbuncle, which can be many centimeters in size. The typical lesion of a Staphylococcus aureus infection is an abscess which undergoes a central necrosis and usually drains to the outside of the skin. This infection type is pyogenic and produces localized inflammation. Staphylococcus aureus can also cause further disease by producing host-damaging toxins. The virulence factors of Staphylococcus aureus include exozymes like hyaluronidase, coagulase, and staphylokinase. Exotoxins like toxic shock toxin, exfoliative toxin, and hemolysin, and protein A. The nose is the main site of Staphylococcus aureus colonization. 30% of people are colonized at any one time. The chronic carriers of Staphylococcus aureus have an increased risk of skin infection by Staph aureus. The skin, especially in hospital personnel and patients, is also a common site of Staphylococcus aureus colonization. Hand contact is an important mode of transmission. Additional sources of Staphylococcus infections include shedding from lesions and fomites such as towels and clothing that have been contaminated by those lesions. Drainage, whether spontaneous or surgical, is the cornerstone of abscess treatment. Incision and drainage is often sufficient for a furuncle or a boil. Previous infection gives only partial immunity to reinfection by Staphylococcus aureus. Antibiotics are usually given afterward. In the U.S., 90% or more of Staph aureus strains are antibiotic resistant. The current recommendations for methicillin-sensitive infections are beta-lactam antibiotics. The exfoliative toxins of Staphylococcus aureus are responsible for staphylococcal scalded skin syndrome. The toxins disrupt the desmosomes that link adjoining cells through the use of a serine protease enzyme, which, through an undefined mechanism, triggers the skin exfoliation. The result is a split in the epidermis at the granular level, and this event is responsible for the superficial desquamation of the skin that typifies the scalded skin syndrome illness. The toxin is the result of a lysogenic conversion of the Staphylococcus aureus. Secondary infections to scalded skin syndrome can also be very problematic. The toxin can also be encoded by a plasmid. Staphylococcal scalded skin syndrome most often affects newborns and children. The illness may vary from localized blister formation to exfoliation of much of the skin surface. Prevention of the spread of Staphylococcus aureus infections in the hospital setting involves hand washing and careful attention to appropriate isolation procedures. The use of topical antimicrobial agents, for example, mupirocin, to eliminate nasal colonization and/or chlorhexidine to eliminate cutaneous colonization with Staph aureus and to prevent subsequent infection has been used successfully in a number of clinical settings. Impetigo is a superficial infection of the skin, and it is caused primarily by Streptococci or Staphylococcus aureus. Impetigo is most often seen in young children, and it tends to occur during the warmer months and is more common in semi-tropical or tropical climates than in cooler regions. Infection is more common among children living under conditions of poor hygiene. The individual lesions begin as red papules, which evolve quickly into vesicular and then pustular lesions that break down and coalesce to form characteristic honeycomb-like crusts. The lesions generally are not painful, and patients do not appear ill. Fever is not a feature of impetigo. Treatment of streptococcal impetigo is the same as that for streptococcal pharyngitis. In view of evidence that Staphylococcus aureus has become a relatively frequent cause of impetigo, empirical regimens should cover both streptococci and Staphylococcus aureus. Antibiotic treatment includes penicillin or erythromycin and a regimen of cleanliness. Early in the illness, Rocky Mountain spotted fever is difficult to distinguish from many self-limiting viral illnesses. Fever, headache, malaise, myalgia, nausea, vomiting, and anorexia are the most common symptoms during the first 3 days. The patient becomes progressively more ill as vascular infection and injury advance in the body. Rocky Mountain spotted fever is all too often recognized only when late severe manifestations prompt a return to a physician's office or hospital admission to an intensive care unit. The Rocky Mountain spotted fever rash is evident in only about 14% of patients on the first day of illness and only 49% of patients during the first 3 days. Small macules between 1 and 5 millimeters appear first on the wrists and ankles and then on the remainder of the extremities and the trunk. Later, more severe vascular damage results in frank hemorrhage at the center of the maculopapule and produces petechia that will not disappear when they are compressed. Rocky Mountain spotted fever organisms are the result of infection with rickettsial bacteria. They're inoculated into the skin along with the secretions of the tick that is biting the human, along with secretions of the tick's salivary glands after the tick has been feeding for about 6 hours. The rickettsia spread via the blood and lymph throughout the body and infect numerous endothelial cells. The dose-dependent incubation period is about a week long, but can range between 2 and 14 days. Occlusive thrombosis, which is the formation of a blood clot inside a blood vessel, and ischemic necrosis, which is necrosis caused by a lack of oxygen resulting from local deprivation of blood supply, results from Rocky Mountain spotted fever infection. The fundamental pathologic basis for tissue and organ injury is that there's increased permeability of the capillaries with resulting edema, low drastic drop in blood volume, and ischemia. Rocky Mountain spotted fever occurs in 47 states, with the highest prevalence in the south central and southeastern states, as well as in Canada, Mexico, and Central and South America. The bacterium is maintained principally by trans-ovarian transmission from one generation of ticks to the next. Rickettsia can be acquired by uninfected ticks through the ingestion of a blood meal from small mammals that are already infected with Rickettsia. The drug of choice for the treatment of both children and adults with Rocky Mountain spotted fever is doxycycline, except when the patient is pregnant or allergic to the drug. The avoidance of tick bites is the only available preventive approach. The use of protective clothing and tick repellents, inspection of the body once or twice a day, and removal of ticks before they inoculate Rickettsia into the body reduces the risk of infection. Lyme disease was recognized as a separate entity in 1976 because of geographic clustering of children in Lyme, Connecticut, who were thought to have juvenile rheumatoid arthritis. It became apparent that Lyme disease was a multisystemic illness that primarily affects the skin, nervous system, heart, and joints. In 1982, a previously unrecognized spirochete, now called Borrelia burgdorferi, was recovered from Ixodes scapularis ticks, and then from patients with Lyme disease. The entity is now called Lyme disease or Lyme borreliosis. The infection usually begins with a characteristic expanding skin lesion called erythema migrans. It's the bullseye skin rash that is diagnostic for Lyme disease. After several days or weeks, the spirochete may spread from the bite point to many different sites. This is called stage 2 or disseminated infection. The possible manifestations of disseminated infection include secondary annular skin lesions, more bullseyes, meningitis, cranial neuritis, peripheral neuritis, carditis, and a musculoskeletal pain that appears to migrate to different parts of the body. Months or years later, usually after periods of latent infection, it's observed an intermittent or persistent arthritis, chronic encephalopathy, polyneuropathy, or acrodermatitis, which may develop. These symptoms are referred to as stage 3 or persistent infection. Most patients experience early symptoms of the illness during the summer, but the infection may not become symptomatic until it progresses to stage 2 or stage 3. Lyme borreliosis, again, is caused by a spirochete whose full designation is Borrelia burgdorferi sensu-lato, that is transmitted by ticks of the Ixodes complex. After injection into the human skin, Borrelia burgdorferi may migrate outward, producing the bullseye lesion, and will spread through the bloodstream or the lymph system to other organs. The only known virulence factors of Borrelia burgdorferi are surface proteins that allow the spirochete to attach to mammalian proteins, integrins, glucosamines, or glycoproteins. Lyme borreliosis is spread by the tick that is visible here in the diagram. Ixodes ticks have larval, nymph, and adult stages. They require a blood meal at each stage of their lives. The risk of infection in a given area depends largely on the density of these ticks as well as their feeding habits and animal hosts. For Ixodes scapularis in the northeastern United States, the white-footed mouse and certain other rodents are the preferred hosts of the immature larvae and the nymphs. It is the tiny nymphal stage tick that is primarily responsible for the transmission of the disease to humans during the early summer months. The various manifestations of Lyme disease can usually be treated successfully with orally administered antibiotics. The exceptions to this are objective neurologic abnormalities and the later third stage atrioventricular heart blocks, which are generally treated with intravenous ampicillin or ceftriaxone. Lyme disease is summarized in Table 22.8.